This conference will now be recorded.
Good morning, everyone. Today, my seminar topic today for seminar is alcoholic liver disease. As you all are now in fifth semester, after entering into the final year, the main topic of interest is this alcohol liver disease. It's an essay question as well as a 4 marks question, and that is very crucial for the practical purpose also and viva also. So before going to the actual topic of discussion, that is alcohol liver disease, I will give a brief introduction regarding the metabolism of alcohol, how alcohol is metabolized in our body. So alcohol, that is ethanol or ethyl alcohol, is readily absorbed by the stomach and intestine. That is particularly the duodenum. Duodenum is the major part where the alcohol is absorbed. So among that absorbs, after it absorbed, only 1% of the alcohol consumed is excreted through lungs, urine, and sweat. And major fraction of the alcohol is oxidized in the liver. So alcohol gets oxidized in the liver by alcohol dehydrogenase to acetaldehyde. So this alcohol dehydrogenase is a major enzyme that plays a crucial role in the metabolism of alcohol. So coming to the alcohol dehydrogenase and its functions, it is an NAD plus dependent cytoplasmic enzyme. It oxidizes ethanol to acetaldehyde, and this acetaldehyde is ultimately converted into acetic acid. So this metabolism of alcohol occurs both in liver as well as in extra another places where the another system, that is microsomal oxidizing system. For the first part of the major contribution, that is alcohol is metabolized by this alcohol dehydrogenase enzyme. It oxidizes ethanol to acetaldehyde. ADH alcohol dehydrogenase is a dimer and has 6 isoenzymes. In some individuals, the enzyme is mutated. So what if mutation occurs? So if mutation occurs in such individuals, alcohol metabolism is slower, and even small quantity of alcohol may produce symptoms of intoxication. So you might get it that in case the enzyme is mutated. So normally this alcohol, whatever the person consumes alcohol, it is completely oxidized by the acetaldehyde or dehydrogenase. But whereas in case if this enzyme is mutated in our body, so even minute quantities of alcohol intake may produce severe symptoms. That's severity is nothing but intoxication. So acetaldehyde is further oxidized to acetate by a mitochondrial NAD plus dependent enzyme, and this acetate is then converted to acetyl CoA. So this acetyl CoA then enters into the tricuspid acid, as you are familiar in the first year subject, that biochemistry. So the rest of the thing goes on. That the activity of ADH is more than aldehyde dehydrogenase. Acetaldehyde accumulates in the liver because, so what is the main pathology in this alcoholic liver disease is because acetaldehyde, which is very toxic and even may cause lead to the cell death. So this is the main pathogenesis. So why alcohol liver disease occurs is because if this conversion doesn't occur, this acetaldehyde gets accumulated within the hepatocytes, which ultimately lead to the necrosis and cell death. So in brief, this flowchart is a pictorial image that representing alcoholic metabolism. So here you can see that ethanol is converted into acetaldehyde in the presence of an alcohol dehydrogenase enzyme, which is very crucial in this metabolism of alcohol. So in the NADH, replace nicotinamide adenine dinucleotide gets reduced to the NADH, and this ultimately this acetaldehyde is again converted into acetic acid. Acetic acid, which is non-toxic, whereas if this alcoholic dehydrogenase enzyme gets mutated or any deficiency, then this acetaldehyde gets accumulated, which is the major crucial factor. It plays a crucial role in the pathogenesis of alcoholic liver disease. So as I mentioned earlier, that another mechanism through which this alcohol gets metabolized is microsomal ethanol oxidizing system. So it is another mechanism of detoxification of alcohol. It is cytochrome P450 dependent and is inducible. So ethanol can be oxidized in the liver microsomes to acetaldehyde by a mixed function oxidase. The electron donors are ethanol and NADPH, by which oxygen is reduced to water. So this microsomal ethanol oxidation system is a part of the superfamily of cytochrome P450, all of which catalyze similar reactions. About 10 gene families and 100 different cytochrome P450 molecules are available. The isoenzyme with highest activity towards ethanol is designated as CYP2E1, where 2 refers to the gene family, E refers to the subfamily, and 1 refers to the particular enzyme. So coming to the biochemical alterations in alcohol. So what are the alterations seen? There is metabolism of alcohol, that is both by dehydrogenase, that is alcohol dehydrogenase and acetaldehyde dehydrogenase, involves the consumption of NAD plus and consequently a high NADH and NAD plus ratio. So what this suggests means, if this NAD plus DH quantity gets increased, this is mostly responsible for metabolic alterations observed in the alcohol. So what happens is, if this NAD plus gets increased, so it involves in the pyruvate cycle. So pyruvate cycles and ultimately that pyruvate, it gets converted into lactic acid, so which leads to the lactic acidosis, which is very toxic to the human body. So here we can see that the lactic acidosis. What are the consequences of this? If anything gets deficiency or any alterations in this alcohol metabolism, that leads to some of the complications, like among these which lactic acidosis, hypoglycemia are the major. So we can see when the patient will coming to the casualties, the drunken person or a alcohol intoxicated person, initially we may find that we will check for the GRBS, he will land into hypoglycemia. So why he will land into hypoglycemia is the major reason is the deficiency of pyruvate leads to the inadequate formation of oxaloacetate. This results in the depression of gluconeogenesis, leading to hypoglycemia, because this oxaloacetate is the non-carbohydrate source. So what is meant by gluconeogenesis is the synthesis of glucose other than the carbohydrate sources. So this non-carbohydrate source, that is oxaloacetate, this deficiency leads to because of this formation of excess of oxaloacetate, this resulted in the depression of gluconeogenesis, leading to hypoglycemia. So next complication is lactic acidosis. Because of this high concentration of NADH, this favors the conversion of pyruvate to lactate, which may lead to the lactic acidosis. So this reduced oxaloacetate, decreased pyruvate, and high NADH causes suppression of tricarboxylic acid cycle. So acetyl-CoA is accumulated, which favors ketogenesis. As I mentioned earlier, this further ketogenesis is lands into the patient may land into the lactic acidosis. So increased level of acetyl-CoA causes increased fatty acid synthesis, but fatty acid is not oxidized. This is the major crucial step where this pathogenesis of entire alcoholic liver disease is a major role here. The increased level of acetyl-CoA causes increased fatty acid synthesis. So this fatty acid synthesis keeps on increasing, but the oxidation does not occur. So as a result, this fatty acid gets accumulated within the hepatocytes, this further leading to the fatty liver. So this is the first step in the, so we will be having 3 stages of alcoholic liver disease. That is the stage of fatty liver, then the stage of steatohepatitis, then fibrosis, then finally cirrhosis. So among these 3 stages of pathology, the first stage, that is fatty liver, this is the only stage where the patient gets reversible. So if the patient gets abstinence from the alcohol consumption or excessive alcohol consumption or alcohol absence, if they get rid of it, then the patient may get this condition may be reversible. So increased concentration of serum uric acid due to its reduced excretion is observed in alcoholism. So this is due to lactic acidosis, as I mentioned earlier. So alcohol may have various effects on various systems, that is the central nervous system, cardiovascular system, and again gastrointestinal system. So alcohol causes CNS depression by inhibiting excitatory receptors, N-methyl aspartate receptors, and by potentiating inhibitory neurotransmitter GABA receptors. So now we will be coming to the effects. Also, we had a brief discussion on the how alcoholism metabolizes. Now coming to the chronic effects of alcoholism. So what happens if the patient is an excessive alcohol abuse, or if may addiction, or if you have chronic alcoholism? So what happens? So as I mentioned earlier, it has effects on various systems like gastrointestinal system, central nervous system, cardiovascular system. So coming to the first, alcoholism and its effects on liver. So what happens if a patient consumes excessive alcohol, or if we have a alcohol abuse, or if we have a chronic alcoholism? So what happens? We will see. So accumulation of fat in the liver cells leading to the fatty liver. So as I mentioned earlier, so what happens is excessive fatty acid synthesis occurs. So this fatty acids keeps on synthesis keeps on going on. As a result, these fatty acids gets accumulated within the liver. As I mentioned earlier, these fatty acids are very toxic to the hepatocytes. So these should be oxidized, but because of excessive fatty acid synthesis, this oxidation process does not take place in pace with the synthesis. So this leads to the accumulation of the fatty acids within the hepatocyte. So thus leading to the fatty liver. So this accumulated toxic effect of acetaldehyde leads to the cellular death and replacement by the fibrous tissue. So this line is very, very important because this is the major crucial role. This plays a crucial role in the pathogenesis of alcoholic liver disease. So this fibrosis of liver is called as cirrhosis, and we'll not go in detail in cirrhosis today's class because cirrhosis is one of the very, very important topic. It should be dealt in a separate class. So I will be giving a brief note on the just only initial stage of alcoholic liver disease, like stage of fatty liver, stage of hepatitis, and the fibrosis and cirrhosis. So these are, and cirrhosis class will be dealt in separate complete class. So when liver functions are reduced, hepatic coma results. So what happens, as I mentioned, let's say if there is hepatocyte failure, that means the patient may land into liver cell failure. So in liver cell failure, if the patient lands in liver cell failure, then he may land into hepatic coma. That is protein degradation may not occur since ammonia synthesis excess keeps on going on. So because of this ammonia, which is very toxic to the nerve cells, so further patient may land into confusion, comatose state, and you have this hepatic coma. Hepatic coma means the excess synthesis of ammonia. This ammonia will be converted into ammonium ion. This ammonium ion is very toxic to the nerve cells. So that is what, because of the damage to the nerve cells, the patient may be presenting to us in various conditions like altered sensorium or any restlessness, asterixis. So these are all the consequences. The patient may land into hepatic coma. This is what is meant by hepatic coma. So now coming to the alcoholism and its effect on nervous system. So in chronic alcoholics, the brain ventricles are enlarged, neurons are lost, neurodegenerative changes occur. So in alcoholics, combined thiamine deficiency leads to the Wernicke's disease. So because of this excess alcoholic consumption, in some of the patients, it interrupts the vitamin thiamine absorption. So because of this, if the thiamine deficiency occurs because of this alcoholics, it may leads to the confused state, or it's a psychogenic state that is called as Wernicke's disease or Wernicke's encephalopathy. So for these patients, what an alcoholic, we will immediately, if a drunkard person or if any alcohol intoxicated person comes to the casualty, so first we will see whether the patient is in hypoglycemia or not. If the patient is in hypoglycemia, so we immediately give him a dextrose, 5% dextrose or 25% dextrose. Then after immediately giving the 25% dextrose, then we'll check for the GRBs. If the sugars gets elevated, then we will give thiamine, because this thiamine deficiency vitamin is very, very crucial in this alcoholic patient, because if this deficiency may lead to the confused state. So that's why to counteract this, what we'll do immediately is in alcohol intoxicated patient, we will give thiamine. We will prescribe them with thiamine, so like 1 gram, or depends upon the patient condition. So this is about Wernicke's disease. So what aldehyde inhibits pyridoxal phosphate, and neuritis is very common in alcoholics. So now coming to the alcohol and its effects on cardiovascular system. So mild alcohol intake, that is red wine, that is less than 20 milligram per day, will marginally elevate HDL and reduce the risk for myocardial infarction to a certain extent. So what is this HDL and LDL? The HDL is nothing but high density lipoprotein, and LDL is low density lipoprotein. So this HDL is good for our human body. So high density lipoprotein is good for our body, whereas LDL is a bad cholesterol. So otherwise called as HDL is a good cholesterol, LDL is a bad cholesterol. So because of this alcohol intake, this LDL will be keeps on increasing. This LDL, that is the bad cholesterol, this cholesterol gets accumulated within the intimal of the these blood vessels. So further leading to the formation of plaques, erythematous plaques. This erythematous plaques, in some conditions like in old age people or above 50 years people, this keeps on increasing. This LDL levels keeps on increasing, and as a result this gets deposited within the vessel walls, and is leading to the erythematous plaques. When this erythematous plaques rupture, what happens is this erythematous rupture, and this leads to finally resulting in the occlusion of this coronary vessels or any brain vessels. So further leading to the ischemia. If it occurs within the heart, then it is called as myocardial ischemia, and if it occurs in the brain, it is called as infarct, that is brain infarcts. So a small percent of alcohol is eliminated through lungs. So lungs also share the deleterious effects of alcohol. So now coming to the actual topic of interest, that is alcoholic liver disease. So what happens if the patient consumes alcohol in very excessive quantity, or if he is a chronic alcoholic, what happens? Then we will see now. So this chronic and excessive alcohol ingestion is a major cause of liver disease and is responsible for nearly 50% of the mortality from all cirrhosis. So no need to take the notes because this all this taken up from the Harrison, which is a, so you can just go through it. The slides are we will prepare from the Harrison, and the initial part, that is alcohol metabolism, is prepared from Satyanan, as you are all studied in the first year, biochemistry Satyanan. So no need to take the notes. We just follow these slides. These are all taken up from the Harrison text. So the chronic and excessive alcohol ingestion is a major cause of liver disease and is responsible for nearly 50% of the mortality from all cirrhosis. So why this alcoholic liver disease we are discussing is because it's very crucial. Day-to-day life, you'll be seeing like a number of cases after completion of the MBBS. You will be some people will be working in the primary health center, some people will be working in the medical institutes. So wherever you everywhere, you will be seeing this kind of patients. That's why I have selected this topic initially, because you people will be after you're getting filling from this MBS, you will be working in different places. So majority of the people you will be seeing this alcohol intoxicated patients. So that's why it's very important to know that this alcoholic patient, because every person who consumes alcohol may not fall into this alcoholic liver disease. And further slides you will be getting that. So why it is important is you should know the stage, how, so whether this patient is in alcoholic liver disease or not. So because of the so that we can act timely. So if his patient is in initial stages of alcohol consumption, that is his excessive alcohol abuse, so then you may advise him for get abstinence from this alcohol. So you may explain the deleterious effects of this alcohol, as I mentioned earlier, that is on cardiovascular system, nervous system, and gastrointestinal system, so that you can make aware of these conditions to the patient, and you may counsel him. So if you get abstinence from the alcohol, then the patient may get reversible changes. So if he is in initial stages, that is stage of fatty liver, if he gets rid of this alcohol or abstinence from the alcohol, this condition is completely reversible. That is why it's very important to know how this pathogenesis takes place and how the consequences of this alcohol liver disease. That's why it's very important. So coming to the pathology of alcoholic liver disease consists of three major lesions with the progressive injury rarely existing in a pure form. That is, it occurs in three stages. That is stage of fatty liver, stage of alcoholic hepatitis, and cirrhosis. So this is a important essay question for your people in the final year examinations. You will have a long note, you may have a short note, and it's very important for practical and viva purpose also. You will be getting this as a long case in practical examinations. So in the first three stages, that is fatty liver, stage of fatty liver, alcoholic hepatitis, and cirrhosis. So among these three stages, this fatty liver, this is the first stage. So this is the only stage where the patient is reversible. This condition is completely reversible. So as I mentioned earlier, why it is important to stage the patient, because if the patient initially comes with kind of symptoms of like right upper quadrant abdominal pain, any nausea, or vomiting sensation, then if we suspect, if we ask detailed history, they may give the history of that is chronic alcohol since 10 years. Then if you see the changes, initially we will advise him for the ultrasound abdomen. So if the changes of fatty liver changes was noted in him, if we give a counseling, if you get abstinence from this alcohol at right now, you may get this condition may be completely reversible, and you may lead normal life. So, but in the stage of alcoholic hepatitis and cirrhosis, this is the further stages. In the advanced stages of this alcoholic liver disease, these stages may be not reversible. So in this condition, in these patients, this alcoholic hepatitis, he may land into fibrosis, then fibrosis, he may land into cirrhosis, and ultimately 2% of these people may land into hepatocellular carcinoma. So why this is important is because ultimately, if the patient is untreated or left like that, he may land into hepatocellular carcinoma, but that is only very minute things. Only 2% of the alcoholic liver disease patients may land into hepatocellular carcinoma. So other stages like this fatty liver, alcoholic hepatitis, cirrhosis, among this fatty liver is reversible. So coming to fatty liver is present in greater than 90% of daily as well as binge drinkers. So a much smaller percentage of heavy drinkers will progress to alcoholic hepatitis, thought to be a precursor to cirrhosis. The prognosis of severe alcoholic liver disease is small, and the mortality of patients with alcoholic hepatitis concurrent with cirrhosis is nearly 60% at 4 years. So why, as I mentioned earlier, not all the alcohol. So if a person consumes alcohol, means that he may not land into alcoholic liver. It has some certain criteria. That means the person might be taking around binge drinking episodes every day for a period of about 10 years. So if he continuously consumes alcohol that is more than the threshold level for a particular day for a period of about 10 years, he may land into this alcoholic liver disease. So although alcohol is considered as a direct hepatotoxin, only between 10 and 20% of alcoholic will develop the alcoholic hepatitis. So what I told earlier, this is all these lines were taken from the Harrison, is a standard book. So you may not take the notes. You just follow the slides carefully, and after this you just give a reading so that you can follow. So the explanation for this apparent paradox is unclear, but involves the complex interaction of facilitating factors such as drinking patterns, diet, obesity, and gender. See here in this science, what he explains is that only the drinking patterns and the diet that the person follows and the nature of this one, that the obesity and its gender. These are the factors that influence the drinking of alcohol. That is, whether the person may land into alcoholic liver disease or not. These are the factors that determines. Not only simply that the consumption of alcohol will land into alcoholic liver disease. There are no diagnostic tools that can predict individual susceptibility to alcoholic liver disease. So coming to the now etiology and pathogenesis, the quantity and duration of alcohol intake, as I mentioned earlier. So this is the crucial fact. Quantity and duration of alcohol intake are the most important risk factors involved in the development of alcoholic liver disease. The role of beverages types, that is different types of alcohol like wine, beer, or spirits, and pattern of drinking and daily versus being drinking are less clear. So coming to spirits, why is spirits so important? Means the formic acid, like in Telugu we'll say the Nadsara. These are the people. These were suddenly land into very deleterious effects. This methanol alcohol poisoning is very common in our states like Andhra Pradesh and Telangana. This alcohol methanol, because of this toxicity, the patient may land into severity. This retinal toxicity may also occur. So some people may get into blind also. So that's why very important that methanol in our state. These are most common in like tribal areas or something, and in our both the states. This drinking is very common in our states. So progress beyond the fatty liver stage seems to require additional risk factors that remain incompletely defined. Means this alcohol after in some patients purely alcohol consumption may not land into the alcohol liver disease. Along with this alcohol, if the patient gets infected with a viral disease like hepatitis C, in that condition both the alcohol intake as well as the co-factor like hepatitis C virus, these both so gets operated, and this results in a very typical situation, that is the stage of steatohepatitis. In this condition, these patients were very aggressive. Aggressive means this disease will be aggressive in these people when compared to alcohol intake alone. So although there are genetic predispositions for alcoholism, gender is a strong determinant for alcoholic liver disease. So women are more susceptible to alcoholic liver injury when compared to men. So keep an eye on this slide. Is very important slide. What are the risk factors for alcoholic liver disease? So see, as I mentioned all the earlier slides, this slide is very crucial. So you kindly see this slide carefully. So what are the risk factors for the alcoholic liver disease? Quantity, as I mentioned earlier, in men, that is 40 to 80 gram per day of ethanol produces fatty liver. 160 gram per day for 10 to 20 years causes hepatitis or cirrhosis. Only 15% of alcoholics develop alcoholic liver disease. So this is all self-explainable. So coming to the second risk factor, gender. Women exhibit increased susceptibility to alcoholic liver disease at amounts greater than 20 gram per day. 2 drinks per day is probably safe. See, so you can compare this here. In men, that is 40 to 80 gram per day, whereas in women, if the quantity is just 20 gram per day is enough for the production of this fatty liver. So coming to the next third risk factor, that is hepatitis C. Hepatitis C infection concurrent with alcoholic liver disease is associated with younger age for severity, more advanced histology, and decreased survival. See what I explained earlier. See, if alcoholic liver disease alone occurs in a patient with a purely history of an alcohol, then that he may land into fatty liver or stage of hepatitis or stage of fibrosis. But when combined with this viral infection or any in younger age, if he is infected with the hepatitis C virus, in that condition it will be very severe. This explains. So coming to the genetics, the fourth risk factor is genetics. So patatin like phospholipase domain containing protein 3, that PNPLA3, has been associated with alcoholic cirrhosis. And coming to the fatty liver, alcohol injury does not require malnutrition, but obesity and non-alcoholic fatty liver are risk factors. Patient should receive vigorous attention to nutritional support. See, another variant, see, alcoholic liver disease In some people, some age group that are above 40 years, some people may land into fatty liver. If you ask them, is there any history of alcohol? Then he says, so no, sir, I've never consumed alcohol in my entire life. So no, then how will you interpret that in that patient? So another term that is called as non-alcohol fatty liver disease. So in these patients, other than alcohol, some people will be having say like junk foods, like excessive fat content foods, like in that people, this fatty liver may develop. So that in that patient, they are called as non-alcoholic fatty liver disease. Other term is called as NASH, that is non-alcoholic steatohepatitis. It's very difficult to differentiate between the non-alcoholic steatohepatitis and alcoholic steatohepatitis. The same features, if you see in the coming slides, I will be showing the histology slides. If you see the both sides carefully, you will be very difficult. It is very difficult to differentiate between them, between the NASH and the alcoholic liver disease. So only it's clinical through the proper history taking. If you ask the history, if the alcoholic liver disease patient gives a proper history of binge drinking or alcoholic abuse, then you will be fitting into the alcoholic liver disease. So, but if there is no history, but still the changes of alcoholic steatohepatitis are seen in a non-alcoholic patients also, then the term is known as non-alcoholic steatohepatitis, that is NASH, NASH. So they developed advanced liver disease with substantially less alcohol intake. That is women. The woman develops advanced liver disease with substantially less alcohol index when compared to the males. In general, the time it takes to develop liver disease is directly related to the amount of alcohol consumed. It is useful in estimating alcohol consumption to understand that 1 beer, 4 ounces of wine, or 1 ounce of 80% spirit all contain 12 grams of alcohol, which is lethal to the for the production of fatty liver or alcoholic liver disease. The threshold for developing alcoholic liver disease is higher in men, that is greater than 14 drinks per week, while women are at increased risk for liver injury by consuming greater than 7 drinks per week. So coming to gender dependent, the gender dependent differences result from poorly understood effects of estrogen, proportion of body fat, and the gastric metabolism of alcohol. As LCM earlier mentioned that among the men and women are more likely to affect from this alcohol level even in small quantities. There is no proper explanation, but the theory suggests that because of the effects of estrogen, proportion of body fat, and the gastric metabolism molecule, these deleterious effects of alcohol are more common in women when compared to that of men. So coming to the next risk factor, there is obesity and a high fat diet, and the protective effect of coffee have been postulated to play a part in the development of pathogenic process. Now coming to the chronic infection with hepatitis C. So as I mentioned earlier, hepatitis C is an important comorbidity in the progression of liver injury and hepatitis C infection develop decompensated liver disease at a younger age and have poorer overall survival. This line is very important. See once again, patient with both alcoholic liver injury and hepatitis C infection. So both the co-infection with alcoholic liver patient with the co-infection like hepatitis C virus develop decompensated liver disease. That is early, what we earlier discussed. It takes around 10 years in a normal patient, but in a patient of hepatitis C infection, if this alcohol liver disease occurs, then he will have a very poor overall survival. So the increased liver iron stores and rarely porphyric cutaneous attack can occur as a consequence of this overlapping injurious process secondary to alcohol and hepatitis C infection. So coming to the pathogenesis, the pathogenesis of liver injury is unclear, but the present conceptual foundation is that alcohol acts as a direct hepatotoxin. That's one of the role that occurs in pathogenesis. Hepatotoxin means that it has a direct toxic effect on the hepatocyte. Another is the inflammatory cascade. Why this inflammatory cascade occurs is because of this ingestion of alcohol and this metabolism. Variety of metabolic responses leads to this inflammatory cascade, which further plays in the role of hepatitis, that is steatohepatitis. So the steatosis from lipogenesis. Earlier we said that because of this excess fatty acid synthesis and because of this oxidation does not occur, so this fatty acid keeps on synthesis in the hepatocyte, and further this acetaldehyde, which is toxic to the hepatocyte, leads to the cell death. So see here, steatohepatitis from lipogenesis, fatty acid synthesis, and depression of fatty acid oxidation appears secondary to the effects on sterol regulatory transcription factor and peroxisome proliferator activated receptor alpha, PPAR alpha. So this and third one is that intestinal derived endotoxin. This also plays a role in the pathogenesis of alcohol liver disease. This is intestinal derived endotoxin initiates a pathogenic process through toll-like receptor spore and tumor necrosis factor alpha that facilitates hepatocyte apoptosis and necrosis. See, previous slide I have said that inflammatory cascade. This inflammatory cascade is nothing but because of this formation of this tumor necrosis factor alpha, and this leads to the apoptosis and necrosis. So the cell injury and endotoxin release initiated by the ethanol and its metabolites also activate innate and adaptive immunity pathways, releasing pro-inflammatory cytokines. Example, tumor necrosis alpha, chemokines, and proliferation of T and B cells. The effect of chronic alcohol ingestion on intestinal permeability influences liposaccharide hepatic influx as well as microbiome dysbiosis, further contributing to the pathogenesis process. The production of toxic protein aldehyde adducts, generation of reducing equivalents, and oxidative stress also play a role. Hepatocyte injury and impaired regeneration following chronic alcohol ingestion are ultimately associated with stellate cell activation and collagen production, which is a key event in fibrogenesis. See, among this all the previous two slides, this is an important slide. See, this explains that because after the hepatic injury, what happens is this impaired regeneration occurs. So if impaired regeneration occurs, this whatever the disturbed collagen, this will not get inhibited properly, and this even further leads to the fibrosis. So in the first initially stage of fatty acid, that is fatty liver, this fatty acid keeps on accumulating. Then this causes this perivenular. So what happens is in this stage of fibrosis, what happens with collagen defective synthesis occurs. This further leads into fibrosis. This is the resulting fibrosis for continuous alcohol use determines the architectural derangement of the liver and associated pathophysiology. So coming to pathology, the stage of fatty liver, stage of steatohepatitis, and the stage of fibrosis and cirrhosis. So fatty liver is the initial and the most common histologic response to hepatic stimuli, including excessive alcohol ingestion. So what happens is this accumulation of fat within the periventricular hepatites coincides with the location of alcohol dehydrogenase, the major enzyme responsible for alcoholic metabolism. So what happens is if continuing alcohol ingestion, this continuing alcohol ingestion results in the fat accumulation throughout the entire hepatic lobule. So despite extensive fatty chain and distortion of the hepatocytes with microvesicular fat, the cessation of drinking results in normalization of hepatic architecture and fat content. See, this slide explains if the patient gets if the patient in the stage 1, that is fatty liver, means this extensive fatty accumulation in the hepatocyte occurs. If the patient intervene the patient in this stage and we ask them for you get abstinence from alcohol, all these stages, whatever the excess fat deposition occurs, this gets reversible. So as a result, this hepatic architecture and it gets normalized. So alcoholic fatty liver has traditionally been regarded as entirely benign, but similar to the spectrum of non-alcoholic fatty liver disease, the appearance of steatohepatitis and certain pathological features such as giant mitochondria, periventricular fibrosis, and macrovesicular fat may be associated with progressive liver injuries. In the coming slides, I will be showing all this, whatever I am saying the pathology. There are slides. I will be showing that that histologists. Right now, we will be in second year. You will be seeing all these slides, but in clear imaging, I will be showing in the next slides. So the transition between fatty liver and the development of alcoholic hepatitis is blood, because we cannot differentiate from which stage it is entering into the transition stage. We cannot differentiate. The hallmark of alcoholic hepatitis is hepatocyte injury characterized by, see here, note these terms, remember this term: ballooning degeneration, spotty necrosis, polymolecular infiltrates, and fibrosis. in the perivenular and pre-sinusoidal space of this is very, very important. This is the stage of steatohepatitis and fibrosis. I will be showing in the next coming slide this histological changes. Malarial dengue bodies are often present in florid cases, but are neither specific nor necessary to establish the diagnosis. Alcoholic hepatitis is thought to be a precursor to the development of cirrhosis. However, like fatty liver, it is potentially reversible with the cessation of drinking. Cirrhosis is present in up to 50% of patients with biopsy-proven alcoholic hepatitis, and its regression is uncertain even with abstention. So see here the pictorial stages of liver disease. So first stage, that is normal liver. Then how see here that accumulation of fat, that is leading to the fatty liver, and this after the accumulation of fat, this collagen degeneration, that is perivenular region, the collagen defects will occur, so leading to the fibrosis, and ultimately this fibrosis leads to nodular like structures, that is cirrhosis. So again cirrhosis, there will be stages like micronodular cirrhosis, macronodular cirrhosis, that will be a different entity, and we will explain in further classes. See here we can see that clear whatever I have explained until now, this is clear imaging. See here we can see in a normal healthy liver, if the patient abuse of alcohol and if there is excess abuse of alcohol, what happens? If there is abuse of alcohol, you can see you will land into liver steatosis. If excess of abuse of liver, then we will name it as alcoholic steatosis. So both these conditions, liver steatosis as well as alcoholic hepatitis, are reversible. So if the patient keeps on abusing of alcohol, then is ultimately will be landing into cirrhosis of liver. So here see we can see the among chronic alcohol patients, normally 90 to 100% will develop alcoholic liver, fatty liver. Among these patients who are after developing fatty liver, among the patients developed with a fatty liver, again 10 to 35% will be landing into steatohepatitis, and among that 8 to 20% will be landing into cirrhosis, and finally 2% will be landing into hepatocellular cancer. So here so you can see the how the ethanol is converted, acetaldehyde, ethanol is converted to acetaldehyde, and then NADH production. This NADH production further leads to increased lipogenesis, decreased fatty acid oxygen, that is fatty liver, and because of this oxidative stress, as mentioned, this is the microsomal ethanol oxidizing system. That because of the oxidative stress, that fatty acid syndrome, then acetaldehyde, which is toxic to the hepatocyte, leading to the hepatocyte injury. So here we can see the defective increased collagen synthesis, leading to the liver fibrosis. So this is the normal histology of a normal liver. See here you can see the portal triad at the periphery of the lobule, and the arrow mark indicating the central vein at the center of the lobule. And here these are depicting cords of hepatocyte radiating from the central vein towards the portal triads. So why this? Next we will be comparing with this alcoholic liver disease patient's histology. So this is the normal liver microscopy. See now here you can clearly appreciate here. See you can the central halo white lobular structures. You can see that these are the fatty inclusions, and you can see the eosine which like malarial bodies. So these are the hallmark for this alcoholic liver disease. This malarial dengue bodies and fatty inclusions. You will be noting. You will be seeing in the histology lab also in the second year. In the pathology, you will be seeing this fatty inclusions and malarial dengue bodies. These are the characteristic of alcoholic liver, the stage of fatty liver and the stage of steatohepatitis. So see here, these are the slides indicating the stage of fibrosis and cirrhosis. So what happens here is in the left side of the slide, you can see the micronodules. See around that, this all the blue structure, that is the eosine structure, fibrous septa blue, enwrapping this nodules. See that is this entire this fibrosis. So here see the micronodule. Here you can see the macronodule. So this is the cirrhosis, typical picture of histology of cirrhosis patient. So as I mentioned, that cirrhosis may be micronodular, macronodular, or mixed people. So this entire micronodules and macronodules is surrounded by a fibrous tissue. This is the stage of fibrosis along with the cirrhotic nodules. So this in brief what I previously shown, that how the chronic alcohol abuse patients will land into steatosis, then how will land into fibrosis, and then how it will land in cirrhosis. This is the percentage numerical data. So how much percentage of people will be affected with steatosis, and how much percentage of people will land into the fibrosis. So here see ultimately that is 3 to 10%. That is in detail that is 2%. 2% of the patients will finally ultimately landing into the hepatocellular carcinoma. So coming to the clinical features, the clinical manifestations of alcoholic fatty liver are subtle and characteristically detected as a consequence of patient. So main complaints is on if you examine the patient or if you palpate the abdomen of the patient, you will find hepatomegaly. And other features that the patient may complain is right up important discomfort, nausea, and rarely jaundice. So in every instance where liver disease is present, a thoughtful and sensitive drinking history should be obtained. Because why? Because if this patient gives the history only, then only you can conclude him as alcohol liver disease. If other than if the patient does not give any history, then you should be think of NASH, that is non-alcohol steatoid hepatitis. So alcoholic hepatitis is associated with a wide variety of clinical features, and fever, spider jaundice, abdominal pain, and an acute abdomen represent the extreme end of the spectrum, while many patients will be entirely asymptomatic. So these see spider jaundice, abdominal pain, and portal hypertension, these all that are the complications of cirrhosis. This will be dealt in separate class, that is cirrhosis of liver. Portal hypertension, ascites, or varicella can occur in the absence of cirrhosis. Recognition of the clinical features of alcoholic hepatitis is central to the initiation of an effective and appropriate diagnostic and therapeutic strategy. It is important to recognize that patients with alcoholic cirrhosis often exhibit clinical features identical to other causes of cirrhosis. So coming to the laboratory features. So the patient with alcohol liver disease are often identified through routine screening tests. The typical laboratory abnormalities seen in fatty liver are non-specific and include more modest elevation of aspartate aminotransferase, alanine transaminase, and gamma glutyl transpeptidase, often accompanied by hypertriglyceridemia and hyperbilirubin. See, this line is very important. In alcoholic hepatitis, and in contrast to the other cause of fatty acid, AST and ALT are usually elevated 2 to 7 folds. They are rarely greater than 400 international units, and the ratio as per the AST to ALT ratio is greater than 1. This is very, very important. This is crucial for the diagnosis of alcoholic steatoid. So see this slide. This is very, very important. Kindly note it out or remember this slide. Very, very important slide. So here see we can see the test AST that is increased 2 to 7 fold, less than 400 international units and greater than ALT. ALT increases 2 to 7 fold, that is less than 400 international units per liter. AST to ALT ratio is usually greater than 1 in alcoholic fatty liver and alcoholic hepatitis. Gamma GGTP, not specific to alcohol, easily inducible, elevated in all forms of fatty liver. Bilirubin may be markedly increased in alcoholic hepatitis despite modest elevation in alcoholic phosphatase. So among these standards, let's see here the diagnosis. We can initially the fatty liver can be detected by ultrasonography. Is useful in detecting fatty infiltration of the liver and determining the liver size. See, coming to the prognosis. So critically ill patients with alcoholic hepatitis are short-term 30-day mortality rates greater than 50%. That is, severe alcoholic hepatitis is heralded by coagulopathy, anemia, serum albumin concentration less than 2.5 milligram per deciliter, renal failure, and ascites. So we can predict the patient. So if the alcoholic hepatitis patient, he may land into any complications or not by this criteria, that is serum albumin levels, anemia, by seeing anemia, prothrombin time, and if serum bilirubin levels and renal failure, we predict the outcome. So whether the patient may be deteriorating or he may be improving. And another scores like discriminant function calculated, that's MELD score. In the next slide, that is the MELD score. If it is greater than 21, also is associated with significant mortality in alcoholic hepatitis. The presence of ascites, varicose hemorrhage, deep encephalopathy, or after-renal syndrome suggests a pretty dismal prognosis. The pathologic stage of the injury can be helpful in predicting prognosis. Liver biopsy should be performed whenever possible to establish the diagnosis and also to get therapeutic use. So coming to the ultimately the final part, that is treatment. Alcoholic liver disease, complete abstinence for alcohol is the cornerstone in the treatment of alcoholic liver disease, and improved survival and the potential for the reversal of histologic injury regardless of the initial clinical presentation are associated with the total avoidance of alcohol ingestion. Referral of the patients to the experienced alcohol counselors and also alcohol treatment programs should be routine in the management of patients with alcohol liver. See, in this slide, in the treatment part is very, very important. As mentioned earlier, if we detect the patient early in the stage of fatty liver, then it's very easy for the treating the patient, because simple counseling, that is, you should get rid of the alcohol or any alcohol abstinence is enough for this patients to become normal. So if the patient keeps on consuming the alcohol, then the next, if the patient lands in the stage of hepatitis, alcoholic hepatitis, Then the mainstay of treatment is the steroids. That is, glucosteroids have been extensively evaluated in the treatment of alcoholic hepatitis. Then the patients with severe alcoholic hepatitis defined as a discriminant function, that is MELD score greater than 20 or 32. Thus, how will we be giving this patient that is steroids? So initially we will start the patient on 40 milligram per day or the prednisone 30 milligram per day for 4 weeks. Then we will taper the dose slowly. That is by reducing 8 milligram per day. So the 32, then we will be reducing, making it to 24. Then we making it to, then keeps on reducing 8 milligram per day, like by tapering slowly at the end of 4 weeks. So this is the flowchart depicting the treatment protocol. That is, alcoholic hepatitis, alcohol abstinence and nutritional support at the initial stage. Then followed by, we will be calculating the MELD score and we will be grading the severity of this alcoholic steatitis. Then if it is greater than 21 or 32, then we will exclude the exclusion criteria, and we will make sure that the patient is not having any gastrointestinal bleeding, renal failure or pancreatitis. Then we will be prescribing this prednisone, that is 32 milligram per day or 40 milligram per oral daily for 4 weeks. Then we'll slowly taper the dose. We should not stop the steroids in the middle. We should gradually taper. Otherwise, the symptoms will get again worsen back. So patients with infection can be concurrent treated with antibiotics and steroids, and women with encephalopathy from severe alcoholic hepatitis may be particularly good candidates for glucocorticoids. So another drug that is in studies are now in treatment of this patients are pentoxifylline. So what is the role? Means the role of TNF alpha expression and receptor activity in alcoholic liver injury has led to an examination of pentoxifylline, the non-specific TNF inhibitor, either by itself or with glucocorticoid for severe alcoholic hepatitis. In one study, pentoxifylline demonstrated an improved survival in the therapy of severe alcoholic hepatitis, primarily due to a decrease in hepatorenal syndrome. Subsequent clinical trials failed to find an increased benefit from pentoxifylline either by itself or in combination with prednisone. So last ultimate is with the patient from first stage, that is fatty liver, to steatosis, then it land into cirrhosis. Then what is the ultimate treatment? Is the final treatment mode of treatment, liver transplantation. This is an accepted indication for treatment in self patient with complication of cirrhosis secondary to alcohol abuse, and outcomes are equal or superior to the other indications for transplantation. In general, transplant candidates should be reevaluated after a defined period of publicity. So patients presenting with alcoholic hepatitis have been largely excluded from transplant candidates because of the perceived risk of increased surgical mortality and higher rates of following transplant. So that's why before going to the main treatment, the ultimate treatment, liver transplantation, we will be giving the initial stages of hepatitis. We will be giving the patients with steroids, and if he's not responsive to that, then we'll give pentoxifylline. And ultimately, after initial medical management, if the patient fails, not get reversible, or if not get any symptomatically relief, then ultimately we'll go for transplantation. So why this captain ended means liver transplantation? Because of surgical mortality. Surgical mortality is very high. So a European multidisciplinary group has reported excellent long-term transplant outcomes in highly selected patients with florid alcohol hepatitis. General application of transplantation in such patients must await confirmatory outcomes. Thank you.